Hello folks, welcome to week 8 and the second part of our biopsychosocial needs, death and dying unit. So before we get back into talking about the needs of our patient populations, let's go a bit more in depth about therapeutic communication. We're going to recap from our communication unit. So from our communication unit, you know that therapeutic communication is between you or any other healthcare professional and the patient or the patient's family. So therapeutic communication should be non-judgmental and supportive, and it has certain characteristics. So a couple of characteristics of therapeutic communication is it should be goal-directed and have a specific purpose. It should be unique to each patient, so people can easily detect canned communication, which isn't effective towards helping our patients feel comfortable or helping us to meet their needs. So they can tell when communication isn't authentic between those two people. Therapeutic communication requires active engagement. It requires excellent observation and listening skills in order to be effective. So remember from our communication unit that there's a sender and a receiver in communication. So as the receiver in therapeutic communication, it's your job to provide a therapeutic response. So a great therapeutic response will include cue giving. Cues are the actions and words that encourage the patient to continue communicating. You could use restatement, which is a good tool. It's when you restate the patient's comment in a way that takes in the underlying meaning. It helps them to know that you're understanding what they're communicating to you. So this doesn't mean that you parrot the patient, but rather that you paraphrase and use your own words to convey that you understand the meaning of their words. So now let's talk a little bit about those special patient populations that we've been talking about. This slide contains some high-risk patient populations. High risk means it's a patient who has one or more comorbid diseases that endanger the outcome of the surgery. So a comorbid disease is any disease or condition that's in addition to the one being treated. So an example would be if we have a malnourished patient in surgery to repair a broken hip, they're in surgery for the broken hip, but the malnourishment is the comorbidity because it could have an effect on the success of that procedure. So the malnourished patient lacks nutritional reserves that are needed in order to support the healing process of surgery. In this way, the malnourishment could affect the outcome of surgery. Diabetic patients are at a higher risk of infection because their vascularity is affected by their disease. Our tissues need blood flow in order to heal. With decreased blood flow, like in many diabetic individuals, healing can be inhibited and infection risk increases because of the longer healing times. Blood sugar in the OR is monitored very carefully in the diabetic patient. The patient's normal insulin dose is decreased prior to surgery because they may end up hypoglycemic as a result of the anesthetics and because of their NPO status. They may try to schedule diabetic patients early in the day in order to get them back on an eating schedule as soon as possible. Finally, because of the diabetic patient's decreased sensation and blood flow in the extremities, these patients are at a greater risk of pressure sores. So positioning is very important, and great care is taken to ensure adequate padding is used when positioning those patients. Surgical patients with respiratory disease are at high risk for developing postoperative pneumonia. There's a risk that they may fail to regain voluntary respiration function after surgery and end up needing to be on a ventilator. Some examples of these patients would be smokers, asthmatics, and those suffering from COPD like emphysema. Alcoholic or drug-addicted patients are considered to have comorbid conditions because they're often nutritionally depleted. This increases their risk just like a malnourished patient. So they may have multiple organ failure or disease as a result of their alcohol or drug use. The surgical team should be aware that 30 to 80% of substance abuse patients also have an underlying mental illness which contributes to their addiction. Most often, this is an anxiety disorder, panic disorder, depression, or bipolar syndrome. And depending on the patient's drug of choice, communicating clearly with the patient may present its own challenges. Immunocompromised patients are at greater risk of surgical site infection as well. They may be immunocompromised for several reasons. Organ transplant patients are given immunosuppressant medications, and some autoimmune diseases like MS, lupus, and rheumatoid arthritis are treated with immunosuppressant drugs as well. Some cancer medications will also cause immunosuppression in the patient. Patients with HIV and AIDS are immunocompromised as well. You should be aware of these symptoms that the patients may have. Skin rashes and lesions are common because the body isn't able to fight them off as a person with a normal immune system would be able to. They may have poor nutrition, painful joints, cardiovascular complications, or generalized malaise, which is just the feeling of being unhealthy. Patients with HIV or AIDS have a very compromised immune system, and they may be suffering from opportunistic infections. Kaposi sarcoma is commonly seen in AIDS patients. The picture on the right on this slide here of that man with the spots on his chest, the picture shows lesions on the chest, which are actually external lesions, and these external lesions may interfere with proper grounding pad or EKG monitor placement in the OR. Grounding pads and EKG monitors require a very smooth connection with the skin, so having those lesions may interfere with that. The picture on the left on this slide is Kaposi sarcoma lesions in the esophagus, which is considered an internal lesion. Now, these lesions are painful, and esophageal lesions may make swallowing difficult. As a result of this, the patient may have weight loss and muscle wasting. Bony prominences may need more padding than usual as a result as well. Intubation may be difficult if the lesions are present in the trachea, and if the patient has intestinal lesions, they could cause bowel obstruction or other intestinal symptoms like nausea and vomiting and diarrhea. This could lead to malnourishment and dehydration, which we already know is a comorbidity in itself. The pain from these lesions, these Kaposi sarcoma lesions, and other sources may be severe enough that extra moving help should be used to transfer this patient as smoothly as possible to and from the OR bed. Blankets placed on the patient over those external lesions should be moved or rearranged as little as possible to avoid any friction on those external lesions, which would be painful and possibly cause harm as well. So treating a trauma patient can sometimes be complicated by the fact that there's no time or opportunity to obtain a medical history on that patient. The surgical team may not know about the patient allergies or pre-existing conditions. Trauma patients may also have injury to more than one body system. For example, a car crash victim may have a broken hip, dislocated shoulders, and a concussion all at the same time. A gunshot victim may have more than one body system affected because a bullet travels where it pleases. The golden hour is a term that's used to refer to the fact that trauma patients have a better chance of survival and recovery if treated as soon as possible after injury or within the golden hour. Trauma is either classified as blunt or penetrating. Blunt trauma is what results from motor vehicle accidents, falls, sports injuries, and being hit with a fist. Penetrating trauma is from a foreign object passing through the tissue. This might be a bullet or a knife wound. Your book does a really great job of explaining blunt and penetrating trauma more in depth on page 67. So we're going to talk now about the pediatric patient. Kids need surgery for the same reasons as everyone else: congenital anomalies, disease, and trauma. Even though this is the case, they are physiologically so different from adults that they're considered special needs patients. Even normal vital signs are different in the pediatric patient. Heart rate and respiratory rate are both higher in young children. Your book has 3 great tables on page 52. That's tables 4.1, 4.2, and 4.3. And they outline the physiological differences pretty well. Be sure to take a good look at those. If you'd like, take a moment to pause the video here to do so. The airway of a pediatric patient is more difficult because of the small size and short trachea. IVs are more difficult to place as well because, again, small size of the vessels. Temperature regulation is more difficult with children as well because of their small size. They actually have a larger skin surface in relation to their size, and that means that more skin surface for their body to lose heat out of. Add to this the fact that babies under 6 months old cannot shiver yet, and the OR is cold, and the OR bed is cold. The pediatric patient is at a major risk of hypothermia. So for this reason, the heat in the OR is usually turned up for a pediatric patient. We'll also frequently warm the bed up before the patient arrives by placing a bear hugger or a warm blanket on the bed. So certain medications should not be given to children as well. Sulfa drugs are very common, but are not to be used because they could cause excess bilirubin in small children. Chloramphenicol is an antibiotic that should not be given to newborns because it could turn their skin gray. And tetracycline is an antibiotic that should not be given to children because it causes staining of their tooth enamel. Finally, great care needs to be taken with medication dosing. Giving an adult dosage of medication to a child or infant could result in great harm to that patient or even death. In addition to all of the physiological considerations of the pediatric patient, we also have to be aware of the psychological needs of these patients. Depending on their age and developmental stage, they're going to have different needs. In infants, which is from birth to 18 months, which is a year and a half, the patients need to be physically near their caregiver. They should be held as much as possible until the procedure begins, and they can also be difficult to comfort because they really need to be close to their caregivers. Toddlers are considered between 19 months and 3 years of age. They suffer from loss of autonomy and separation anxiety. So they may become aggressive or regress and start behaving younger than their age. So we have to remember to practice patience and understanding with these toddlers. Preschoolers are anywhere from 4 to 6 years of age. These kiddos feel extreme fear, and they see surgery as a punishment for some imagined wrongdoing. They are very imaginative, and they may imagine mutilation as part of their procedure. They also interpret concepts literally, so great care needs to be taken when speaking to this age group. For example, put you to sleep may bring up memories of their dog Fluffy going to the vet to be put to sleep and go to heaven, and that may cause them to feel fear. So it's very careful to choose your words very carefully. School-age children are from ages 7 to 12 years, and these kiddos are more compliant typically and more cooperative with healthcare providers. They may withdraw from caregivers and be sensitive about their bodies being exposed. School-age patients often want to help with their care and feel involved. It gives them some feeling of control. Adolescents are 13 to 16 years of age. They're sensitive about their body image and the changes that are being brought on by puberty. So they may resent what they view as an intrusion of privacy, and they'll likely fear the loss of control. So they want concrete information, and they want to feel in charge. As I mentioned before, monitoring pediatric patients for temperature control is very important because they're at great risk of hypothermia. They cannot self-regulate their temperature the way adults do. They have large skin surface area to lose heat, low body fat to act as an insulator, and patients younger than 6 months can't shiver to try and stay warm. So urine output is used to gauge fluid management, and they may count wet diapers instead of catheterizing because under 6 months old, they cannot place a catheter because the urethra in a patient that young is too small, and it would be injured by placing a catheter. Even a small amount of blood loss is taken very seriously in pediatric patients because the amount of blood that they start with is so small anyways. Finally, oxygenation can be difficult because of the small size of their airways. So let's move on now to talking about the care of obese patients. An obese patient is someone who is 100 pounds heavier than their ideal body weight. The stress on the body from carrying around all that extra weight can cause a number of other health complications. A list of these are myocardial hypertrophy, which is an enlarged heart, coronary artery disease, high blood pressure, varicose veins and edema in the extremities, which is swelling in the extremities, pulmonary function complications leading to increased risk of post-op pulmonary infection, liver and gallbladder disease, osteoarthritis, diabetes, pituitary abnormalities, arteriosclerosis, and dysfunctional uterine bleeding. Also, anesthetic agents from surgery will stay in the obese patient's system longer because of the increased adipose tissue and decreased respiration. So adipose tissue holds on to that medication longer than other types of tissue will. So what does all this mean for us in surgery? What can we do to increase the obese patient's chance for a successful outcome? Well, it's important to be in a safe work environment. So with an obese patient, it's a good idea to call for extra moving help when transferring him or her to the OR bed or back onto the transport cart. Positioning may be difficult, so the staff in the room may ask for help with this as well. A special OR bed can be brought in for the obese patient, but if there isn't one available, 2 regular OR beds can sometimes be pushed together. Remember that OR beds have user instructions and weight restrictions that must be followed. So it's very important to be sure that the patient's skin is also not being pinched or wrinkled. Any skin or tissue folds have to be smoothed out, and careful padding is needed for these patients so that we don't break down their soft tissue and skin. Deeper or longer instruments may also need to be used in order to provide exposure in these patients. So, surgical procedures on pregnant women are avoided whenever possible. Some emergency situations that would require surgical intervention during pregnancy are ectopic pregnancy, appendicitis, trauma, and incompetent cervix. Of course, this is not an entire list of all of the things that could require a pregnant woman to receive surgery, but these are some of the common ones. If surgery is unavoidable, the second trimester is the least dangerous of the 3. By then, optimally, the fetus is stable and the mother's organs haven't been displaced too much because the uterus isn't so big yet. If surgery is done in the first trimester, it increases the chance of miscarriage for that woman. If done in the third trimester, it increases the chance of preterm labor, and the organs could be displaced, making diagnosis difficult. Every effort should be made by the surgical staff to decrease the amount of time that the patient spends under anesthesia. So the anesthetic medications cross the placenta, and the fetus doesn't have a fully functioning liver to help them metabolize very quickly. So the quicker and smoother the procedure can be, the better. That's assuming the patient and staff safety come first. The surgical tech may be able to help the surgeon by palpating the uterus and alerting the surgeon to any contractions. So that may be something that the surgeon asks their tech to do in the room. When a pregnant woman is flat on her back, the baby may put pressure on the major blood vessels in her abdomen, the inferior vena cava and the aorta. So what we can sometimes do is place a roll under her right hip, and that helps to alleviate this pressure. If you look in your book on page 60, there's a really good picture that illustrates this idea of how does a baby place pressure on those great vessels, and how is putting a roll under the right hip going to help. So take a look at page 60. That illustration is very helpful. The room temperature can be increased, just like what we would do for a pediatric patient. Because it's going to help the pregnant patient also avoid hypothermia. Sometimes it may be a good idea to have a just-in-case setup with everything needed for an emergency C-section. And finally, a pregnant patient will have a fetal monitor placed somewhere on her abdomen. So it's important that you know where that monitor is, so that you don't accidentally interfere with it in some way. Let's talk about the geriatric patient. So as we age, we find ourselves at a greater risk for skin, joint, muscle, and bone injuries. During the aging process, the body loses adipose tissue, which means the padding and protection that the fat provided is decreased. So the loss of adipose tissue also means that the body's insulation is decreased. So loss of body heat should be considered a potential problem as well. The skin of a geriatric patient may be dry and fragile, so we need to be very careful with our positioning, with adhesives, and also with transferring from one bed to the other. Geriatric patients may have hearing or vision impairment. If they have a hearing aid, they should be allowed to wear it for as long as possible. The patient may have restricted mobility or range of motion. They may be arthritic and painful, so they should be moved very carefully. Therapeutic communication between yourself and the geriatric patient will likely be different from how you would communicate with another person. You may need to speak more clearly, loudly, and slowly. Don't ever call a patient sweetie, honey, cutie, or any other similar nickname. These may be offensive and belittling to your patient. For example, my grandmother is 95 years old, and I know that if someone called my grandmother sweetie, she would be very irritated by that. So never assume that a geriatric patient is mentally impaired. The normal aging process doesn't include dementia. And finally, respect the patient's privacy the same as you would with any other patient. Don't make assumptions about these patients. The elderly patient goes through many physiological changes that may affect their needs in the OR. This is important to remember as we work with this special population. Many body systems are affected. The following slides list some examples of those changes, and your book has a really great table that outlines these changes really well. It's on page 65. We already mentioned a potentially decreased range of motion. Bone mass decreases as well as strength as we age, and the nervous system is affected, displaying sensation changes and increased pain tolerance, and a decreased ability to tell where your limbs are in space. What position you are in. The lungs lose elasticity, and the chest wall becomes more rigid, which results in less exchange of oxygen. And we already mentioned the loss of elasticity in the skin and thinning as well, which refers to loss of adipose tissue under the skin as well. This leaves us vulnerable to bruising and for the skin to tear as well, like we talked about with those adhesives earlier. In the digestive or gastrointestinal system, peristalsis is slowed down, which could lead to blockage in the GI. Blood pressure is increased in these individuals, and genitourinary changes include a decreased bladder capacity and a decreased kidney function, specifically nephron function. So, how do we meet the needs of this special patient population? Because they have so many factors involved. Your book cites Waters and McLaren's critical factors for obtaining the best outcomes from surgical treatment on geriatric patients. They list 8 factors. 1. Careful preoperative prep of the patient and optimization of medical and physiological status. So this means that a thorough evaluation of the patient is completed, and then they're prepped for surgery as best as possible. For example, blood pressure and clotting factors will be brought to the best possible level. 2. Appropriate anesthesia and physiological monitoring. 3. Recognition of alterations in clinical pharmacology. So for example, what medications does the patient take, and how does surgery affect those medications or the need for those medications? 4. Minimization of the postoperative stresses of hypothermia, hypoxia, and pain. This is addressed by keeping the patient warm using warm blankets or bear hugger type blankets and keeping the patient adequately oxygenated, as well as providing adequate pain control. 5. Prevention of alterations in blood pressure and heart rate. So the patient is monitored closely during surgery. 6. Avoidance of perturbations of fluid, electrolyte, and acid-base state. 7. Careful surgical technique to prevent surgical site or hospital-acquired infection. 8. Optimization of functional level. So this means that the patients function at the level at which that they're able. So if they can walk, they walk, etc. People with Down syndrome often have health concerns that will occasionally necessitate surgical intervention. They may have heart defects, GERD, frequent ear infections, obstructive sleep apnea, or thyroid dysfunction, for example. These patients are often very well adapted to everyday independence in life. However, there may be some impairment in cognitive abilities and also in growth in these patients. So sometimes they also have speech delay, which creates a challenge for effective communication. They may understand more than they're able to actually communicate back to you. So it's important for the surgical team to stay very calm, use patience to help the patient feel comfortable, and to facilitate that communication. If the patient's very young or dependent on a caretaker, that person may accompany the patient to the OR. As with many patients, a quiet OR is more comfortable for a patient with Down syndrome. So if possible, try to pause setting up while the patient is awake so that they don't become anxious with all of the noise. Finally, patients with Down syndrome may have excessive joint laxity and muscle hypotonia, which is decreased muscle tone. They may be more prone to injury, joint injury, or dislocations as a result of this. So because of this, it's important for staff to be very careful while positioning this patient so that they aren't causing injury. PTSD is defined in your book as the result of prolonged exposure to traumatic situations or a series of traumatic situations that's characterized by the patient suffering from long-lasting emotional, psychological, and social problems. PTSD is frequently seen in members of the military after they return from a violent or dangerous situation, rape victims, and adolescents that have been exposed to violence. Some things to remember about patients suffering from PTSD is the severity of the symptoms will be different for everyone. So it's ideal for the surgical team to be aware of the severity of symptoms that their particular patient suffers. That way they can be more prepared for the patient. The patient may be irritable, angry, or aggressive in the OR. Depending on the severity of the patient's symptoms, it may be helpful to have the patient's counselor present in the OR. Substance abuse is common in those suffering from PTSD, so it's important for the OR staff, especially anesthesia, to be aware of that. You should keep the OR as quiet and non-threatening as possible while the patient is awake. Stop working on your back table and Mayo setup when the patient enters the room. You can resume once they're intubated. Also, keep any sharps or other objects that may be perceived as weapons out of sight and out of reach of the patient. Finally, PTSD patients will sometimes have bad days where their symptoms are especially bad. When surgery lands on a bad day, it may be best for all involved to reschedule surgery for a different day, if possible. You may find yourself in a case someday where you need to be responsible for the preservation of evidence. This is the situation when a violent crime has been committed, and evidence of that crime needs to be accounted for by the police. The police will want to have custody of the evidence, and evidence may include the patient's clothing, bullets or bullet fragments, knife fragments, trace evidence like hair, and biologic evidence like blood and body fluids. So be sure to follow your hospital policies very closely in this situation. Remember that even patients who've committed or are victims of violent crimes are still protected by HIPAA. Following your hospital policy very closely when it comes to handling evidence of a crime, especially if it is a specimen taken from a patient, is your best guide. Physically speaking, evidence of a violent crime needs to be handled very carefully. If there are bullets, do not pick them up with a metal instrument. This could scratch the bullet and affect law enforcement's ability to prove which gun it came from. They should be handled as little as possible and not with anything that could damage them. Same with knife fragments and other foreign objects. You wouldn't want the court proceedings against a violent criminal to be negatively affected by your carelessness with evidence. Some patients come through the OR and will be designated as isolation patients. These patients that are affected with serious microorganisms that presents an increased risk of transmission to staff or other patients or visitors. Microorganisms are transmitted in different ways. So droplets, you can think of like flying sneeze droplets, airborne, contact, which can be direct or indirect, vector-borne, like a mosquito carrying the microorganism from person to person, and fomite-borne, like picking up a microorganism off of a shopping cart handle that an infected person touched. There are different types of isolation for patients depending on how the microorganism is transmitted. So for example, contact precautions will be different from airborne precautions. All isolation patients require the use of additional precautions to prevent the spread of the microorganism. Patients can often find that being in isolation is very challenging. They may feel stressed psychologically. by the extra precautions, and sometimes they'll only have limited contact with their support system, like their friends and family, which adds to that struggle. Universal precautions are used to prevent disease transmission with all of our patients, but there are some additional things that may be done with isolation patients, not just in the OR, but in all patient care areas. Things like even more frequent hand washing than normal, a specialized mask with higher filtration rates, eye shields, gloves, gowns, respirators, environmental controls like adjusting the air pressure of the patient room, clear communication along the chain of care so that staff can prepare for the patient's arrival to the department, and patient education in order to help prevent future transmissions. So there's a lot of information in these few slides. So this is where we're going to leave off for this week. Next week, we'll finish up this big whopping 3-week unit with our death and dying portion. So thanks for watching.